Hi, everybody. For this week's clinical conference, we have DH, who is an 18-year-old African American female with no past psychiatric or medical history, who was admitted for a suicide attempt via intentional ingestion of Tylenol, 600 milligrams times 400 tablets, naproxen, 200 milligrams times 75 tablets, and a third unknown medication on October 15th around 11 p.m. Her suicide attempt resulted in her having respiratory failure, gap acidosis, and hypokalemia. In addition, her blood alcohol level was 0.65. Her acetaminophen levels in her blood actually increased as time went on, and it got as high as 253. And just for reference for everyone, anything greater than 20 is elevated, and hers was 253. Her liver enzymes, her AST, and her ALTs were somehow miraculously not affected, but they were ranging between 17 and 20. She was then intubated and started on NAC or N-acetylcysteine protocol per poison controls recommendation. I actually found an article that talks about N-acetylcysteine, which is the first line therapy for Tylenol intoxication, and it is close to 100% effective if given within 8 hours of ingestion. And she was taken to the emergency room shortly after she overdosed. So, this could be the explanation as to why her liver enzymes were not elevated at all. So, she had intervention soon after her overdose. So, it ended up being very helpful for her. While in the ER, the nursing staff described her as aggressive and agitated, and then she decompensated into a obtundant state. Given her worsening mental status and her respiratory failure, she was then intubated and started on the norepinephrine due to some hypotension that did not respond to a 2-liter normal saline bolus. She was then transferred via survival flight to U of M's PICU as a direct admit for further management and care. As her status started to improve, her respiratory status as well as her mental status started to improve. She was extubated and transferred to the step-down unit. However, she does continue to be on suicide precautions, and she constantly has a patient attendant at the bedside to ensure her safety. So on assessment, her mental status exam, her appearance, she was sitting in bed, dressed in a gown, her hair was disheveled. Her behavior was calm and cooperative, and she was able to maintain appropriate eye contact during our interview. She was also attentive and answered my questions appropriately. For her motor activity, she was coordinated with no signs of abnormal movements such as tremors, tics, or signs of EPS or catatonia. Her speech was soft, articulated at a normal pace, and was fluent. Her mood she described as good. Her affect, she showed a full range of emotions and became tearful during our interview. Her thought content, she denied current SI or thoughts of dying, and she had no signs of thought blocking or loosening associations. Her thought process, she had no signs of delusions, obsessions, or depersonalizations, auditory or visual hallucinations. Her insight was poor because she felt that she didn't need inpatient psychiatric care, and her judgment before was poor also because she did not volunteer to be admitted to a psychiatric inpatient hospitalization. So we ended up having to petition and insert her. Her intellectual functioning, her fund of knowledge was intact. She was able to tell me who the president was. And so, in regards to her diagnosis is one is major depressive disorder, XS2 was deferred, XS3 was acetaminophen intoxication, XS4 she has some pretty significant social stressors of not getting along with her father and being sexually harassed at work. She has reported feelings that her life is quote resolves around sex. She felt like her life revolves around sex, which was very concerning. And also, Axis 5, we gave her a 40. So we will continue to monitor and follow her. And let me know if you have any questions.